Welcome back, everyone. I'm really excited for today's deep dive because we're going into the world of neurology and pharmacology with a focus on epilepsy and the medications, the drugs that are used to treat it. And I think this will be especially interesting for you given your nursing background, right? And the fact that you're still hitting the books. Pretty cool.
Oh, yeah. Yeah, definitely. I mean, it's fascinating. Some of these medications have been around forever, like for decades, and still there's so much we don't know about them, about how they work.
Right, that's true. And it's way more common than people think, epilepsy. It affects millions of people all over the world. So yeah, let's start by defining it. Like, what exactly is epilepsy? And the textbook does a good job of, breaking it down and separating it from like seizures and convulsions.
Okay, so epilepsy, it's a chronic neurological disorder, right?
Yeah.
And the big thing is it's characterized by these recurrent seizures.
Yeah.
And seizures, well, those are like these brief episodes of abnormal electrical activity happening in the brain.
Got it. And convulsions, where do those fit in? Like, what's the difference?
So a convulsion, that's like a more extreme, more severe type of seizure. And it involves like your muscles, they start contracting involuntarily, and it can affect like your whole body. So basically all convulsions are seizures, but not all seizures are going to have convulsions.
Okay, yeah, that's a really important distinction to make. So we've got epilepsy as the disorder, the overall condition, and then the seizures are those individual events, with the abnormal brain activity. Now, the book talks about primary epilepsy and secondary epilepsy. Can you like expand on that a little?
Sure, sure. So primary epilepsy, sometimes called idiopathic epilepsy, means there's no clear cause, like we can't identify anything specific that's causing it. But then you've got secondary epilepsy, and that one, well, that's a result of some other underlying condition.
Interesting. Okay, so what kind of things, what conditions can lead to that secondary epilepsy? I bet as a nurse you see that pretty often.
Oh, absolutely. As a nurse yourself, you're familiar with things like head trauma, infections, strokes, all those things. Those can trigger epilepsy to develop.
Makes sense.
Yeah.
And what about febrile seizures? Some kids experience those. I remember, like early in my nursing career, how scary those were for parents.
Oh, yeah. Febrile seizures, they're usually brought on by a high fever, right? And it's understandable why parents would freak out a little. But the good news is they usually don't mean there's a long-term problem. Kids, they typically grow out of them. And most of the time, simple fever reducers like acetaminophen or something, that's enough to manage the fever and prevent the seizures from happening.
Okay, yeah, that is reassuring, especially for parents who are, worried. Now, about the different kinds of seizures, the textbook gets into that in quite a bit of detail, even mentioning the older terms and the newer ones.
Right, right. So the way we classify seizures now, it's based on like where they start in the brain and what the person's awareness is like during the seizure. So we can start with what people used to call grand mal seizures. Now we call them generalized onset seizures.
Generalized onset, meaning it involves like both sides of the brain.
Precisely. The abnormal electrical activity, it starts at the same time in both hemispheres of the brain. And these seizures, they can look different, different ways they present. But the classic one, the one everyone kind of pictures, is the tonic-clonic seizure. And that starts with the tonic phase. That's where the muscles all over the body, they stiffen up.
And then comes the clonic phase, right, with the jerking rhythmic movements.
Yeah, exactly. So the clonic phase, it comes right after the tonic phase. And usually during a tonic-clonic seizure, the person, they lose consciousness.
Wow. Okay. That sounds really serious. So are there other kinds of generalized onset seizures?
Yes, there are. You have tonic seizures where it's just the stiffening part, no jerking. And then clonic seizures, those are just the jerking movements. And then you've got absent seizures. Those used to be called petit mal seizures.
Oh, right. Absent seizures. Those are the ones where like the person just seems to zone out for a second, right?
Yeah, yeah, you got it. It's like a really brief lapse in their awareness. Sometimes they stare or blink a lot. These are more common in kids, and luckily they're usually super short, just a few seconds.
Okay. So we talked about generalized onset seizures. What about the ones that like begin in just one part of the brain?
Those are called focal onset seizures. They used to be
Nah.
partial onset seizures. And the symptoms, they can be all over the place. Really depends on where in the brain the seizure is starting.
I see. So like two people could have a focal onset seizure, but their symptoms could look totally different.
Exactly. And their awareness during the seizure can be different too. Some people, they know exactly what's happening, while others, their consciousness is kind of altered. They might have weird sensations like smelling or tasting something strange, or they might have motor symptoms like their arm or leg starts twitching or jerking. It's a pretty wide range of possibilities.
So I imagine diagnosing and treating those focal onset seizures, that can be pretty tricky.
It can be,
The
yeah.
textbook also mentions unknown onset seizures. What can you tell us about those?
Well, those are the ones where we're not sure where in the brain they're starting or what the person's awareness is like during the seizure. So, more research is definitely needed to understand those better. But let's shift gears a little and talk about a very serious type of seizure. Status epilepticus.
Status epilepticus. Yeah, that doesn't sound good.
It's not. It's a real emergency. It's when a seizure goes on for too long, like way too long, or when someone has a bunch of seizures in a row without recovering in between.
So the seizures are basically just happening one after another, no break.
Right, and that can lead to some really serious complications, even brain damage or even death.
So acting quickly is like super important.
Absolutely, you got to act fast. And medications like diazepam or lorazepam, those are often used to try to stop the seizures as quickly as possible.
That makes sense.
Mhm.
All right, let's move on to how we treat epilepsy, specifically the meds, those drugs that are used to control seizures. The book calls them anti-epileptic drugs, or AEDs, instead of anticonvulsants.
Yeah, and that's because, these medications, they treat a lot of different kinds of seizures, not just the ones with convulsions.
So anti-epileptic drugs, AEDs, it's a more accurate way to say it.
Okay.
What are the main goals when you're treating someone with epilepsy?
Well, you've got three main goals. First, obviously, you want to get those seizures under control, right? But then you also want to minimize any side effects the medications might cause, and it's super important to help the person maintain a good quality of life.
Yeah. All those things are really important. And I can see how finding that right balance can be tricky, especially because some of these drugs, they do have some pretty significant side effects.
So, how do doctors usually approach like starting someone on AED?
Well, usually you start with just one drug to keep things simple for the patient, limit the burden of all those pills.
Mhm.
And if that one drug isn't enough to control the seizures, then you think about adding more.
Okay, that makes sense. And what about therapeutic drug monitoring? Is that something that's like routinely done with these medications?
For some of them, yes. For drugs like phenytoin, phenobarbital, carbamazepine, and primidone, we keep a close eye on the drug levels in their blood. We do that because there's a clear connection between those blood levels and how well the drug works, and also how likely they are to have toxic effects.
So for those drugs, it's regular blood tests, right? Just to make sure the dose is right. Exactly, but for other AEDs like valproic acid, ethosuximide, clonazepam, levetiracetam, and lamotrigine, we don't routinely check blood levels unless we suspect there might be some toxicity.
Got it. So different drugs, different monitoring. Okay.
Mhm.
Now, the book also mentions this whole debate about generics versus brand name AEDs. Is that something you come across in your practice?
Oh, for sure, yeah, all the time. While generic meds are usually considered to be, basically the same as the brand name ones, there are some concerns, especially among neurologists, about whether they're really as effective.
So some doctors, they're hesitant to switch a patient from a brand name to a generic, especially if the patient's seizures are well controlled.
That's it. The worry is that even a tiny difference in how the drug is made could lead to more seizures. Now, the book doesn't take sides in this debate, but it does emphasize how important it is to be careful and watch the patient closely if you do switch from a brand name to a generic.
So good communication, careful observation, that's key. Okay. Let's get into how these AEDs actually work in the brain.
Hmm.
The book explains that, the exact ways they work, those mechanisms, they're really complicated, but it does give some general explanation.
Right. So basically, AEDs, what they do is they change how ions move. Things like sodium, potassium, calcium, magnesium. They change how those ions move across the membranes of the nerve cells. And these changes, they help to stabilize those nerve cells and prevent them from getting, overexcited, which is what leads to those seizures.
So in a way, they're calming down those electrical storms in the brain,
Mm.
the ones that cause the seizures.
Yeah, that's a good way to think about it. And a key player in all this calming down is a neurotransmitter called GABA. That's gamma aminobutyric acid. GABA's job is to inhibit things, to slow down nerve activity.
I see. So if these medications can boost GABA's activity, they might be able to reduce the chances of seizures happening.
Precisely. And lots of AEDs, they actually do work by making GABA more effective. That helps restore the balance in the brain, between all that excitation and inhibition that's going on. Now, if we want to get into the details, the book, it groups the AEDs into different classes, right, based on their chemical structure and how they work.
Okay, so let's start with the first class, the barbiturates.
All right. The main ones they talk about are phenobarbital and primidone. And these have been used to treat epilepsy for a really long time.
You've been around the block a few times. Is there anything, like, really notable about them?
Well, phenobarbital especially, that one's been used for, forever. And one interesting thing is that primidone, it actually gets converted into phenobarbital in the liver. So when you give someone primidone, you're basically giving them something that will turn into phenobarbital in their body.
Interesting. So the body's, like, processing it, turning it into the active drug. Are there any advantages to using phenobarbital?
One big one is its long half-life. What that means is it stays in the body for a while, so you can often just dose it once a day, which is, it's a big help for people who have trouble remembering to take their meds multiple times a day.
Yeah, from a nursing perspective, I can see how that would be, like, a huge plus. Medication adherence is always tough, so anything that makes the dosing easier, that's a win. But of course, with any medication, there are downsides too. What are some of the common side effects of phenobarbital?
The most common one is sedation. It can make people drowsy or sluggish.
So yeah, that's something to keep in mind, especially for, people who need to drive or operate machinery.
Yeah.
Are there any other potential problems?
Well, phenobarbital is what we call a potent inducer of liver enzymes. That means basically it can speed up how the liver metabolizes other drugs, and that can make those other drugs less effective.
So it's really important to look at all the other meds that patients taking, right, to avoid those potential interactions. What's the next class of AEDs that's in the book?
The next one is the hydantoins, and the two big ones in this class are phenytoin and fosphenytoin.
Phenytoin, I've heard of that one. Is it an older medication?
It is. Phenytoin's been around a while. It's considered like a classic AED, and it's good for both generalized and focal onset seizures. And then you have fosphenytoin, which is basically like a newer version of phenytoin.
So how are they different? Why did they make fosphenytoin?
Well, phenytoin itself, it doesn't dissolve well in water, which makes it tricky to give intravenously. So they developed fosphenytoin to make it easier. It's what we call a prodrug. That means it gets converted to phenytoin once it's in the body. That makes it faster and easier to give IV, which is super important in emergencies, when you need to get that IV access quickly.
Yeah, that makes a lot of sense. Are there any notable side effects with these hydantoins?
One that you see a lot with long-term phenytoin use is gingival hyperplasia. It's basically an overgrowth of the gum tissue, and it can be pretty unsightly, and it makes it hard to keep good oral hygiene.
So yeah, good dental care is super important for people on phenytoin. Anything else to watch out for?
Both phenytoin and fosphenytoin, they have what we call a narrow therapeutic range. That means the difference between a dose that works and a dose that's toxic, it's pretty small.
So it's one of those drugs where you really have to keep a close eye on the blood levels, right? Make sure the patient's getting enough to control the seizures, but not so much that it becomes toxic.
Huh.
Okay, what's the next class of AEDs?
Next up is the imidazolines, and the book focuses on two, carbamazepine and oxcarbazepine.
Okay, carbamazepine. What can you tell me about that one?
Carbamazepine's it's a versatile AED. It's used for a lot of different types of seizures. It can also treat trigeminal neuralgia, which is this condition that causes really severe facial pain.
Oh yeah, I've heard of that. So carbamazepine has multiple uses. What about oxcarbazepine?
Oxcarbazepine is newer imidazolpine, and it's similar to carbamazepine, but often preferred because it tends to have fewer drug interactions.
Fewer drug interactions, that's always good news. I know those can be a real pain, no pun intended, for both patients and for us healthcare providers. Anything else interesting about these drugs?
Yes. This is really important. Carbamazepine, it interacts with grapefruit juice.
Grapefruit juice, really?
It does. Grapefruit juice can actually stop carbamazepine from being metabolized properly. So that can lead to the drug building up in the blood and a higher risk of side effects. So people taking carbamazepine, they have to avoid grapefruit juice altogether.
That's a great example of why it's so important to get a complete medication history from patients, including anything over the counter, even dietary supplements. Anything else about carbamazepine?
Yes, one more thing. Carbamazepine can cause what we call autoinduction of its own metabolism.
Autoinduction, what does that mean?
It means basically over time, carbamazepine can actually make the body produce more of the enzymes that break it down. So that can lead to, lower blood levels of the drug and make it less effective. So sometimes the dose needs to be adjusted to make sure the patient's getting enough.
Wow. That's fascinating. So the body's like learning to break down the drug more efficiently over time. That's a great example of just how complex these medications can be.
It is, yeah. It's like, your own body's working against the medication. Okay, so moving on. The next class of AEDs, those are the sacchinamides.
Cinemides. Okay, that's a new one for me.
The main one in this class, it's ethosuximide. And it's mainly used for absence seizures. It doesn't usually work for other types of seizures, so it's pretty specific.
So it's like a specialist then, huh? In the world of AEDs, I guess that's good for people with those absence seizures to have something that targets those specifically.
It is, yeah. It helps to, minimize the risk of side effects because you're using a more targeted treatment. Now, there's a whole bunch of AEDs that we kind of lump together, the ones that don't really fit into those neat categories we've talked about.
Miscellaneous AEDs, is that like the newer drugs mostly? The ones that haven't been around as long?
Yeah, that's basically it. This group, it includes megs like gabapentin, lamotrigine, levetiracetam, pregabalin, tiagabine, topiramate, valproic acid, and zonisamide. Each one has its own, its own little quirks, what it's used for, and its potential side effects.
Sounds like a lot to keep straight.
Yeah.
So how do providers decide which one's right for a particular patient?
It's all about, taking a good look at each person's situation. What kind of seizures are they having? What other health problems do they have? And what other meds are they on? You have to think about drug interactions. It's like a puzzle, finding the best fit for each person. So, for example, gabapentin, it's often used along with other meds for focal onset seizures, but it's also prescribed for nerve pain a lot, neuropathic pain. So you can see how some of these drugs have like multiple uses.
That's interesting. So someone could be on gabapentin for pain and find that it's helping their seizures too. Are there any downsides to gabapentin?
The most common ones are dizziness and drowsiness. So that's something to watch for, especially in people who need to be alert.
Makes sense. What about lamotrigine? I think I've heard that one mentioned for bipolar disorder.
Yeah, lamotrigine is used for both focal onset and generalized seizures. And it can also help stabilize moods, which is why it's used for bipolar disorder. But there's a risk of a serious skin rash, Stevens-Johnson syndrome with this one.
Stevens-Johnson syndrome. That sounds scary.
It is, yeah. It's rare, but it can be life-threatening. You get these painful blisters, your skin starts peeling. The risk is highest like right when you start the drug those first few weeks. So it's really important to watch the patient closely during that time. And of course, you want to educate them about the signs and symptoms, tell them to get medical help right away if they notice any rash.
Absolutely. Early recognition and treatment. That's crucial with that syndrome. Okay. What about levetiracetam? I've heard that one's becoming pretty popular.
It is, yeah. People like it because it's generally well tolerated and it doesn't interact with a lot of other drugs. It's used a lot as a first-line treatment for both focal onset and generalized seizures. The most common side effects are things like dizziness, drowsiness, and headaches. And some people, they have mood changes, like they get irritable or aggressive.
So it's not just physical side effects you have to watch for, but mental and emotional ones too.
Right, you got to look at the whole picture.
Okay, what about pregabalin? I know that one's often used for nerve pain too, right?
Yep. Pregabalin's a lot like gabapentin. It's used for both seizures and neuropathic pain. It works by binding to calcium channels in the brain and spinal cord, and that reduces the release of, those excitatory neurotransmitters.
So it's calming down those nerves that are firing too much, right?
Exactly. And the common side effects, well, they're pretty much the same as gabapentin, dizziness, drowsiness, and some people gain weight.
Okay, more things to be mindful of when you're, prescribing or giving these drugs.
Mm.
The book also talks about tiagabine. What's that one's role in treating epilepsy?
Tiagabine, it works by increasing the amount of GABA in the brain, but it does it differently than some of the other drugs we talked about. It actually inhibits the reuptake of GABA, so more GABA is available in the synapses, the spaces between the nerve cells. And the side effects you usually see are, dizziness, drowsiness, fatigue, that kind of thing. And one important thing to remember is that tiagabine can interact with other drugs that also depress the central nervous system, like alcohol or benzodiazepines. So you don't want to combine those.
Right, mixing those can be really dangerous. Okay, what about topiramate? I think I've heard of that one too.
Topariate's kind of unique because it actually has multiple mechanisms of action. It makes GABA work better, it blocks glutamate receptors, and it inhibits those sodium and calcium channels. So it's like a multi-pronged attack on those seizures.
Sounds like a pretty complex drug.
It is. It's used for a bunch of different types of seizures and sometimes even to prevent migraines. But it can also cause a whole slew of side effects like cognitive problems, weight loss, kidney stones, and it can interact with some other medications like birth control pills.
Oh, so women who could become pregnant, they need to be told about using other forms of birth control if they're on topiramate. That's really important.
Definitely. Okay, now valproic acid, that's an older AED, but we still use it a lot. It's effective for lots of different types of seizures, and we also use it for bipolar disorder and to prevent migraines. But it has some pretty serious potential side effects like liver damage and pancreatitis.
Those are definitely serious. So what kind of monitoring do you need to do for people on valproic acid?
You gotta watch them closely, especially if they already have any liver problems. Regular blood tests to check liver function, that's a must. And this is a big one, valproic acid, it can cause birth defects. So it's a no-no during pregnancy, and women who could get pregnant, they need to be on reliable birth control while they're taking it.
Absolutely crucial information for both patients and us providers. Okay, last one on our list of those miscellaneous AEDs, zonisamide.
Zonisamide, it's one of the newer ones, and it's actually related to sulfonamide antibiotics. And like those antibiotics, it can cause side effects like skin rash, kidney stones, and something called metabolic acidosis. You have to monitor carefully and always check for potential drug interactions before you prescribe it.
Good point. Always better to be safe than sorry, especially when it comes to drug interactions. So we've been through a lot of AEDs, old ones, new ones. Seems like there are lots of different options, each with its own, pluses and minuses. It's a lot to take in.
It is, and that's why it's so important for nurses to really know these medications inside and out, so we can educate our patients and watch them closely for any problems.
Absolutely. Now let's talk about, the nursing considerations when you're taking care of people with epilepsy. The book really stresses the importance of a thorough assessment.
Oh yeah, that's the foundation of everything. You got to start with a detailed seizure history, right? Find out everything you can, what kind of seizures, how often, how long they last, if anything triggers them, any warning signs, any past treatments they've tried. It's a lot to gather, but it's all important for coming up with a good care plan.
It's like detective work, huh? Putting all those
Yeah.
pieces together to really understand what the patient's going through.
That's a good way to put it. And besides the seizure history, you also got to do a baseline neurological assessment. Check their mental status, how their cranial nerves are working, their muscle strength, their sensation.
So you're looking at the whole neurological system, top to bottom. Are there any lab tests that are particularly important in this context?
Yeah, liver and kidney function tests. You got to know how well their liver and kidneys are working because, a lot of these drugs are processed by those organs. That'll help you figure out the right dose and watch for any potential toxicity.
Makes sense.
Yeah.
It's all about tailoring the treatment to that individual, right? Their specific needs and their body's ability to handle the medication. Now, the book also talks about safety, keeping patients safe when you're caring for them. What are some of the key things to think about?
Safety is huge, especially when you've got someone who could have a seizure. You got to make sure the environment is safe, no clutter, no obstacles they could trip over. And you need to take those seizure precautions like padded side rails on the bed and having suction ready just in case they have trouble breathing during a seizure.
Yeah, those precautions, they can really make a difference in preventing injuries. What about giving the medications, actually administering them? Anything special to keep in mind with AEDs?
Yeah, a few things. AEDs, you got to give them at the times they're prescribed, on schedule. That helps keep those blood levels steady. And usually you give them with food, unless there's reason not to, just to avoid upsetting their stomach. And this is super important. You never crush or chew those extended release pills.
Right, those are designed to release the medication slowly, right?
Exactly. Crushing or chewing them, it messes up that release and can cause the blood levels to go up and down, which can make seizures more likely or increase side effects.
So always check the form of the medication, make sure you're giving it the right way.
Mm.
Okay. Now, patient education, that's always a big part of nursing care, right? Especially with something like epilepsy.
Oh, it's huge. We got to teach our patients all about these meds, how important it is to take them exactly as prescribed. Skipping doses or changing the times, that messes with those blood levels and can bring on seizures.
Yeah, consistency is key.
And we got to teach them about the side effects they might have and what to do about them. And another really important thing is to emphasize that they can't be drinking alcohol or taking other drugs that depress the central nervous system while they're on these AEDs.
Right, because those effects can add up and become really dangerous, even life-threatening.
Exactly. And one more thing, this is really important. You got to tell your patients to let you know immediately if they start having any thoughts about suicide.
Oh, wow. Okay, I didn't realize that was a potential side effect.
It is, unfortunately. Some AEDs have been linked to an increased risk of suicidal thoughts. So patients need to be aware of that and know to reach out for help right away if they start experiencing those thoughts.
So that's a whole lot of information to cover, from how to take the meds to what to watch out for to those potential mental health effects. It really shows how important our role is as nurses in supporting and educating these patients.
It does. We're often the ones they see the most. We have a real opportunity to help them understand their condition and take control of it so they can live full, happy lives.
Absolutely. Okay, now that we've covered the basics of epilepsy care, let's dig a little deeper into those specific objectives outlined in this chapter. The first one is to describe briefly the pathophysiology of epilepsy.
So basically, understanding how epilepsy develops, what happens in the brain during a seizure, all that.
Right, and we've already talked about a lot of that, defining epilepsy as this neurological disorder with the recurring seizures, going through the different types of seizures, how they look.
We've laid a good foundation, I think.
We have.
Yeah.
Okay, second objective is to explain the rationale for using the different classes of AEDs to manage the different forms of epilepsy. And we've covered that too, right? Talking about each class of drugs, how they work, which seizures they're best
Yeah.
for.
Yep, we've connected those dots, how the way epilepsy works ties into the choice of medication.
Exactly. The third objective is to identify all the different drugs within each class. So immunostilbines, benzodiazepines, barbiturates, hydantoins, and then all those miscellaneous ones.
And we've already done that, haven't we? We named each drug and talked about its main features.
We have. Okay, so now the fourth objective, this is where we get into the nitty-gritty, right? Is to discuss the mechanisms of action, indications, cautions, contraindications, dosages, routes of administration, adverse effects, toxic effects, therapeutic blood levels, and drug interactions for each anti-epileptic drug.
Yep, the whole 9 yards. We're going to get specific.
Sounds like we need to, really break down each individual medication.
We do. So let's start with the immunostilbines, specifically carbamazepine. This one works by blocking sodium channels, which helps stabilize the nerve cell membranes and stops them from firing over and over. It's used for a bunch of different seizure types, including focal onset seizures and those generalized tonic-clonic seizures. Now, some things to be careful about are drug interactions, especially with other meds that are metabolized by the liver. You can't use it in patients with certain blood disorders, and the dose needs to be adjusted based on how the person responds and how much they can tolerate. It can be given by mouth or IV, and common side effects are dizziness, drowsiness, nausea, and vomiting. Rarely, but more seriously, it can cause blood problems and liver toxicity. We monitor the blood levels to make sure it's working and to prevent toxicity. And like we talked about earlier, no grapefruit juice with this one.
Okay, so that was a really thorough overview of carbamazepine, covering everything from how it works to potential side effects and those drug interactions. Sounds like there's a lot to think about when you're prescribing this drug.
There is, and that's why it's so important for nurses to know these drugs really well, to be able to teach their patients and keep an eye out for those adverse effects. Okay, another immunostilbin is oxcarbazepine. It's a lot like carbamazepine, but doesn't interact with as many other drugs.
That's definitely a plus, especially for folks who are taking a lot of medications. Okay, moving on to the benzodiazepines. I know these are often used in emergencies, right? To stop seizures fast.
That's right. The main ones we use for status epilepticus are diazepam and lorazepam. They boost the effects of GABA, which calms down all that neuronal activity. They're given IV for quick action, and the usual side effects are drowsiness, dizziness, and slowed breathing, especially if you give them too fast or with other CNS depressants.
So watching their breathing is really important when you're giving these.
Absolutely.
Okay, now let's talk about the barbiturates, specifically phenobarbital. We said earlier this is an older AED, but it's still used.
Phenobarbital also works by enhancing GABA, but it lasts longer than those benzodiazepines. You give it by mouth, and the common side effects are sedation, respiratory depression, and some cognitive problems. And it can interact with other drugs that are metabolized by the liver, so you might need to adjust the dose.
So checking for drug interactions is key with this one. Okay, next up, the hydantoins, with phenytoin being the classic one in this group.
Phenytoin, it mainly works by blocking sodium channels, but it also affects calcium and potassium channels. It's indicated for a bunch of different seizure types, but it's got that narrow therapeutic range, so monitoring those blood levels is crucial. Common side effects are that gingival hyperplasia we talked about earlier, plus nystagmus, which is like jerky eye movements, ataxia, which is problems with coordination, and cognitive issues. And it can interact with tons of other drugs, so you got to be really careful about that when you're prescribing it. Fosphenytoin is basically a form of phenytoin that's easier to give IV.
So phosphatidylcholine is a good option when you need to give it intravenously,
Yeah.
but you still got to watch out for those same side effects and drug interactions as regular phenytoin.
Exactly. Okay, let's move on to those miscellaneous AEDs, starting with gabapentin. We mentioned earlier that it's often used for both seizures and nerve pain. We don't know exactly how it works, but we think it involves binding to those calcium channels. Common side effects are dizziness, drowsiness, and swelling in the legs and feet.
So overall, it's pretty well tolerated, but still important to keep an eye out for those things.
Right. Now, lamotrigine, that's another one of these miscellaneous AEDs that's used for seizures and bipolar disorder. It works by blocking sodium channels and affecting how glutamate and aspartate are released. Those are excitatory neurotransmitters. And remember, we talked about that serious skin rash, Stevens-Johnson syndrome. That's a rare but scary side effect of this drug. So we got to teach our patients what to look for and tell them to get medical help right away if they notice any rash.
Right. It's so important to be vigilant, especially in those early days when someone's starting a new medication. Some of these can have some really serious consequences if you miss those early warning signs. So what about levetiracetam? I understand that's become a pretty popular choice for epilepsy treatment?
It has, yeah. Levetiracetam, it's a newer one, and it's getting more popular because, well, it works for a lot of different types of seizures and generally has a pretty good side effect profile. It's effective for both focal onset and those generalized seizures. We still don't fully understand exactly how it works, but the current thinking is that it modulates neurotransmitter release and affects how excitable the neurons are.
So it's kind of helping to regulate that electrical activity in the brain. What are the common side effects? Anything nurses should be watching for?
The usual suspects are dizziness, drowsiness, and headache. Some people also get mood changes, like irritability or even aggression.
So it's important to pay attention to both the physical and the psychological side effects.
Hmm.
What about drug interactions? Are there any major ones to watch out for?
Actually, one of the nice things about levetiracetam is that it doesn't interact with a lot of other drugs. So that makes it a good choice for people who are taking a lot of medications already, for other health problems.
Yeah, that's a big advantage, especially for older folks. They often have more complicated medication regimens.
Absolutely. Now, pregabalin, we've touched on that one already. It's often used for seizures and neuropathic pain. Structurally, it's pretty similar to gabapentin, and it works in a similar way, binding to calcium channels and reducing the release of those excitatory neurotransmitters.
Right, another one that helps calm down those overactive nerves. So the side effects are similar to gabapentin too, I imagine.
Yeah, pretty much. Dizziness, drowsiness, and some people gain weight.
Okay, so more things to keep in mind and monitor for. What about tiagabine? How does that one work?
Tiagabin, it increases the amount of GABA in the brain, but it does it in a different way than some of the other drugs we've talked about. It inhibits the reuptake of GABA, which means more of it is hanging around in those synapses, those spaces between the nerve cells. Side effects, the usual ones, dizziness, drowsiness, fatigue. And it's really important to remember tiagabin can interact with other drugs that depress the central nervous system, like alcohol and benzodiazepines. So those combinations, you got to avoid them.
Yeah, absolutely. Mixing those can be a recipe for disaster. Okay, what about topiramate?
Topiramate, it's a real multitasker. It works in several ways, actually. It enhances GABA activity, blocks glutamate receptors, and inhibits sodium and calcium channels. So it's pretty versatile, can be used for a lot of different types of seizures, and even to prevent migraines.
Wow, it really does a lot. Are there any downsides?
Well, it can cause a whole bunch of side effects, cognitive problems, weight loss, kidney stones.
Yeah, those are certainly things to watch out for. Any drug interactions to be aware of?
Yes, it can interact with some meds, including oral contraceptives. So women who could become pregnant, they need to know about using backup birth control while they're on topiramate.
Right, really important to counsel them on that.
You're right.
Okay, let's talk about valproic acid. That one's been around for a while, right?
Yeah, valproic acid, it's an older drug, but it's still widely used because it's effective for a lot of different seizure types. Plus, it's used for bipolar disorder and migraine prevention, but it does have some potential for serious side effects, liver damage, and pancreatitis being the big
Yeah,
ones.
those are definitely serious concerns.
Yeah.
So what kind of monitoring is needed?
You got to watch these patients closely, especially anyone with liver problems. Regular blood tests to check liver function are essential. And a really important point, valproic acid, it's known to cause birth defects. So can't be used during pregnancy. And women of childbearing potential, they need to be on reliable contraception.
Absolutely essential information to have. Okay, let's wrap up this discussion of the miscellaneous ADDs with zonisamide.
Zonisamide is one of the newer ones, and it's structurally related to those sulfonamide antibiotics. And just like those antibiotics, it can cause some side effects, things like skin rash, kidney stones, and something called metabolic acidosis. So careful monitoring is needed, and you always want to check for potential drug interactions before you prescribe it.
All right, so a thorough medication review, careful monitoring, all that is super important. So
Yeah.
if I'm hearing you right, the key takeaway here is that we have a lot of good medications for treating epilepsy, but each drug, each one has its own, its own set of pros and cons. Finding the right one for a particular patient, that's a complex process, right? You really have to weigh those benefits and risks carefully.
You got it. It's definitely not one size fits all. And that's where the nurse's role is so crucial. We're often the ones giving these meds, watching for side effects, educating the patients, supporting them.
Absolutely. Nurses are really on the front lines of epilepsy care. They play a vital role in making sure these medications are used safely and effectively, and in helping those patients live their best lives.
Couldn't have said it better myself. Okay, now that we've covered all the different classes of AEDs, let's go over those key terms highlighted in the chapter. These are like the must-knows for anyone who works with patients with epilepsy.
Sounds good. Let's do it.
So first up is anticonvulsants.
Hmm.
That's what we used to call these medications, drugs that prevent or reduce seizures. But like we talked about, the term we use now is anti-epileptic drugs, or AEDs, because it's more inclusive.
Right, AED is the more accurate term. Okay, what's next?
Next is autoinduction. That's the process where a drug actually causes the body to produce more of the enzymes that break it down, which can lead to lower blood levels of the drug over time. Carbamazepine, that's a good example of a drug that can do that.
That's fascinating how the body can adapt like that. Okay, what's next?
Next is convulsion. That's a type of seizure where you have those involuntary muscle contractions. Important to remember, all convulsions are seizures, but not all seizures involve convulsions.
Right, some seizures might involve changes in awareness or sensory things without any visible muscle movements. Okay, what else do we have?
Next up, electroencephalogram, or EEG. That's a test where we record the electrical activity of the brain. It's a key diagnostic tool for epilepsy. It helps us figure out what type of seizure it is and where in the brain it's coming from.
So EEGs give us a lot of information about those seizures. Okay, what's next?
Next is epilepsy itself. It's basically an umbrella term for a bunch of neurological disorders that are characterized by recurring seizures. And these seizures, they can cause a whole range of symptoms: convulsions, sensory disturbances, weird behavior, loss of consciousness, you name it.
So epilepsy is like the broad category, and then there are all these different types of seizure disorders that fall under that. Okay, what's next?
Next is focal onset seizures. Those are the ones that start in a specific area of the brain.
Yeah.
And like we talked about earlier, the symptoms can be really different depending on where that seizure focus is.
Right, so two people could have focal onset seizures, but their experiences could be completely different. What's next?
Next is generalized onset seizures. Those are the ones that start in both hemispheres of the brain at the same time.
So those involve more widespread brain activity, often leading to more noticeable symptoms like loss of consciousness and convulsions.
Exactly. Okay, next one, gingival hyperplasia. That's that overgrowth of gum tissue that we see with long-term phenytoin use. It can make it hard to take care of your teeth.
So good dental hygiene is really important for folks on phenytoin. What's next?
Next is primary epilepsy. That means the epilepsy doesn't have a known cause. It's different from secondary epilepsy, which is caused by some other underlying condition, like a head injury or a stroke.
So with primary epilepsy, it's like a mystery. We don't know what's setting off those seizures. What's next?
Next is seizure itself. That's when there's excessive stimulation of neurons in the brain, leading to this burst of abnormal electrical activity. And that causes temporary changes in how the brain functions, mainly affecting sensory and motor stuff.
Right, so a seizure is like an electrical storm in the brain that throws everything off. Okay, what's next?
Next is status epilepticus. That's that emergency situation we talked about, where a seizure goes on for way too long, or there are multiple seizures without any recovery time in between. It can be really dangerous, even life-threatening, so you got to act fast.
Right, if those seizures don't stop, it can lead to serious brain damage. Okay, what's our last key term?
Last one is tonic-clonic seizures. Those are generalized seizures where you have that initial phase of muscle stiffening all over the body, followed by those alternating contractions and relaxations. That's the classic type of seizure that people picture, the loss of consciousness, the stiffening, the jerking movements.
Right, the dramatic one that we often see depicted in movies and TV shows.
Oh,
Okay, so we've made it through all the key terms. Let's tackle those review questions at the end of the chapter.
yeah, these are always good. Help you see if you're really understanding the material. You ready to test yourself?
Let's do it.
Okay, first question. The nurse is getting ready to give some medications. Which of these is the right way to give IV phenytoin? Select all that apply. A, give IV doses via rapid IV push. B, administer in normal saline solutions. C, administer in dextrose solutions. D, use a filter for IV infusions. E, ensure continuous infusion of the drug.
This one's all about the details of safe medication administration for IV phenytoin.
Exactly, and it's a good opportunity to review some important points about giving this drug IV. First, you never want to give IV phenytoin as a rapid IV push. That can cause serious heart problems. Second, you got to give it in normal saline. If you use dextrose, the phenytoin can come out of the solution and cause a blockage in the ID line.
So the right solution is crucial for safety and effectiveness. What are the other options?
Always use a filter for IV infusions. That's just standard practice to keep any little particles out of the bloodstream. And phenytoin, you give it as a slow IV infusion, not continuously.
Okay, so the right answers are B and D. Administer in normal saline solutions and use a filter for IV infusions. It's a good reminder of how important those little details are, especially with drugs like phenytoin that have that narrow therapeutic range. Okay, next question.
The nurse is checking the medications taken by a patient who will be starting carbamazepine. Which drug could be a concern for interactions? A, digoxin. B, acetaminophen. C, diazepam. D, warfarin.
This one's all about those drug interactions, right? We know carbamazepine can interact with some other medications.
Right. And the answer here is B, acetaminophen. Carbamazepine can speed up how the body metabolizes acetaminophen, which could make it less effective and increase the risk of liver problems.
So not a good combination. What about the other options?
Digoxin, diazepam, and warfarin, those don't usually have any major interactions with carbamazepine. But it's always best to double check, use a drug interaction database or talk to a pharmacist to be absolutely sure, especially when you're dealing with multiple medications.
Always better to be safe than sorry. Okay, next question.
What would you expect to see in a patient with a phenytoin level of 25 millisys GMLO? A, ataxia. B, hypertension. C, seizures. D, no unusual response. This level is therapeutic.
This one's testing our knowledge of phenytoin toxicity, what it looks like in a patient.
Yep, and the answer is A, ataxia. A phenytoin level of 25, that's above the therapeutic range, and it can cause neurological side effects. Ataxia, which is problems with coordination, that's a common symptom of phenytoin toxicity.
So recognizing those signs of toxicity is important, and monitoring those blood levels is key to preventing serious problems. What about the other options?
Hypertension and seizures, those aren't usually seen with phenytoin toxicity. And option D, saying there wouldn't be any unusual response because the level's therapeutic, that's wrong because 25 is actually toxic.
Right, the therapeutic range for phenytoin is much lower. Okay, on to the next question.
A patient's taking pregabalin, but they don't have a history of seizures. What else is this drug used for? A, postherpetic neuralgia. B, viral infections. C, Parkinson's disease. D, depression.
This one's highlighting the fact that some of these AEDs, they have other uses besides just treating seizures.
Right. And the answer here is A, postherpetic neuralgia. Pregabalin's approved for treating nerve pain, including the kind that lingers after shingles.
So these drugs, some of them are pretty versatile. They can be helpful for both seizures and chronic pain.
Okay, next question.
A patient with a history of seizures is admitted to the hospital. During the assessment, the patient has a generalized seizure that doesn't stop for several minutes. Which drug would the nurse expect to be ordered for this condition? A, valproic acid. B, Neurontin. C, carbamazepine. D, diazepam.
This is describing status epilepticus, a real emergency. The go-to drug for stopping seizures quickly in this situation is D, diazepam.
So diazepam would be the one to reach for in that situation. Why not the others?
Valproic acid, Neurontin, which is gabapentin, and carbamazepine. Those are all AEDs, but they're not used for immediate treatment of status epilepticus. They're more for long-term prevention of seizures.
So it's important for nurses to know which drugs are used for prevention and which ones are used for those acute situations. Okay, what's our next question?
The nurse is giving an anti-epileptic drug. Which guidelines should they follow? Select all that apply. A. Monitor the patient for drowsiness. B. Medications may be stopped if seizure activity disappears. C. Give the medication at the same time every day. D. Give the medication on an empty stomach. E. Notify the prescriber if the patient is unable to take the medication.
This is a good review of the general guidelines for giving AEDs.
It is, and the correct answers are A, C, and E. You always got to watch for drowsiness. It's a common side effect of these drugs. Giving the meds at the same time every day helps keep those blood levels consistent and the drug working its best. And if the patient can't take their medication for any reason, they're sick, they have side effects, they can't swallow the pills, whatever it is, you got to let the prescriber know right away.
So consistent dosing and communication with the provider, those are key. What about the other options?
Option B, saying you can stop the meds if the seizures stop. That's a big no-no. Patients should never stop taking their AEDs without talking to their doctor first. Stopping them suddenly can cause more seizures.
That's really important for patients to understand. And D, giving the meds on an empty stomach, that's also wrong. You usually want to give them with food to avoid stomach upset. Okay, 2 more questions to go.
The nurse is getting ready to give phenobarbital. The order says, give phenobarbital IV 2 mg a day at 0,900. The patient weighs 253 pounds. How many milligrams will the patient get for each dose?
Right, dosage calculations time.
First step, convert the weight from pounds to kilograms. There are 2.2 pounds in a kilogram. So a 253-pound patient weighs about 115 kilograms. The order is for 2 milligrams per kilogram per day.
So we multiply 115 kilograms by 2 milligrams per kilogram. That gives us a total daily dose of 230 milligrams.
And since it's given once a day, the patient gets all of 230 milligrams at 0,900.
Perfect. Nailed that calculation. Last question.
The nurse is teaching a patient who will be starting an AED for the first time. Which statement by the patient shows that they need more teaching? A. I will take the medicine at the same time every day. B. I will take with my doctor before taking any over-the-counter drugs. C. I will keep the appointments to check my blood work. D. I can drive to work again once my drug levels are normal.
This one's all about patient education and safety, especially when it comes to driving.
Exactly. And the statement that needs more teaching is D. I can drive to work again once my drug levels are normal. Having the right drug levels is important, but whether someone can drive or not, that's determined by state laws and usually requires a certain amount of time without seizures, not just normal drug levels. You could have the right drug levels but still have a seizure, so it's not safe to assume that normal levels mean you're good to go behind the wheel.
So patients need to know the specific driving laws in their state, and they need to understand that they can only drive again after they've been seizure-free for a certain period of time, as decided by their doctor and the law.
Exactly. The other options, those are all good signs. Taking the med at the same time every day, checking with the doctor before taking other drugs, and keeping those blood work appointments, those are all important for safe and effective treatment.
Well, I think we've covered just about everything there is to know about epilepsy and antiepileptic drugs. We went from the basics of how epilepsy works to the specifics of each drug class. And we even talked about the vital role that nurses play in all of this.
I agree. It's been a thorough deep dive. I hope our listeners found it useful for their nursing practice.
I'm sure they did. It's a great reminder of how important nurses are in making sure these powerful medications are used safely and in helping patients live full lives, even with the challenges of epilepsy.
Well said. Epilepsy is a complex condition, but with the right treatment and support, people with epilepsy can absolutely thrive.
Thanks for joining us for this deep dive into epilepsy and anti-epileptic drugs. Until next time, keep learning, keep asking questions, and keep up the great work.
It's been a pleasure.